Okay, we're going to talk about ultrasound guided vascular access. And the wonderful thing about ultrasound is it gives you sort of vascular real-time eyes where you can see the vessels themselves and the needle going into the vessel. And this makes you more accurate, shortens the time, decreases complications. And there's all kinds of ultrasound guided procedures you can do. All the centeses, abscesses, bladder aspirations, nerve blocks, foreign bodies, LPs, even reducing fractures. Obviously, this lecture is going to be really focused on vascular access, and there's lots of complications that can occur from vascular access, but I think one of the most important things is the patient's more comfortable. There's less redirecting our sharp object around in a patient's soft tissue. So I always think about, like, if I need a central line, I'd sure want the doctor to use ultrasound because it would just be more comfortable. But I'm not the only one that feels that way. It's the Agency for Healthcare Research and Quality, who is sort of a research watchdog looking for all things with lots of good, robust category type 1 evidence behind it. And they came out with a statement a few years ago: ultrasound guidance during central line insertion prevents complications. So for lots of reasons, it's good to use. The literature dates all the way back to 1993. With better success rates, first attempt success rates, skin to vein time, less carotid punctures. And then you fast forward a little closer, 2005, we see this concealed randomized controlled trial, 201 patients, and there was a 53% times higher success rate using ultrasound compared to feeling around for the landmarks in the neck. So how do you do it? You want to use a linear transducer. If you don't have one, you could use an endovaginal transducer. What's similar about these probes is the fact that they both have very high frequency. So you want to use that high frequency transducer. Obviously, this is easier to work with when you're doing one of these. You want to put a sheath over the transducer to keep it covered, keep the sterile technique going. And this is just a video of someone doing just that. You can see the sterile packets come with a sterile packet gel in there. We get that from the sheath packet. So that's why it's good to have these sheath packets. Next to the sheath is that sterile packet of gel. You put the whole thing in your sterile field. You put your hand in the sheath. You pop a little space there for the transducer. An assistant comes along with the transducer that's already got gel on it. Now that gel doesn't have to be sterile since it's going to be inside the transducer. And then you simply roll the rest of the sheath down the cable, and you're good to go at that point. You can put the whole thing down your sterile field. You put the rubber bands on here. It only takes a second to do that. And you're ready to go. There's some gel inside the sheath, and there's also, you're going to put gel on the outside of the sheath. And then you want to make sure that there's no air between the sheath and the probe itself. It's just like all gel there inside, because air is the enemy of ultrasound. Now, if you don't find a sheath anywhere, you can always use a tegaderm. You open up and you put the probe down on the sticky side of the tegaderm, and basically that's what it looks like when you wrap the tegaderm back around itself. And you could use this for central lines, although it's better to use a big, long, sterile sheath. If you have those, go for it. If not, you could always use this. I prefer using the sheath when I'm doing our central line if I have time to get it, but, when my nurses, they're all doing peripheral lines with ultrasound, and they always use a tegaderm in order to get that peripheral line, because it's a quick, sticky job right on the probe itself, and you don't need any gel between the tegaderm and the probe itself. And this is the most important thing you want to remember from the lecture, and that's that the indicator is going to be pointed towards your left, the operator or the procedure doer's left, if that's even a word, I'm not sure. But you've got the indicator. If you're at the head of the bed doing an IJ, this patient's right IJ, you've got the indicator towards your left. That way, things going left to right under the probe will have the same effect along the screen. So, for example, here the needle is coming in on this side of the vessel. Well, we need to redirect and go into the vessel. And as we redirect underneath the transducer, like from right to left in this case, we redirect from right to left. It's going to have the same effect on the screen, not go the opposite direction. So you should commit that to memory. Any procedure, whether you're doing an arthrocentesis or a central line, you're going to be using this concept. Now, keep in mind, we're in the short axis technique. So we've got the vessel in the short axis. We can see it looks like a round structure when it's in the short axis. We're basically bisecting it with the ultrasound beam. Indicators to our left. And then we are going to compress the vessel. See how this IJ down here is nicely compressible next to this carotid? Over here, though, next to this carotid, this IJ is not compressible. So this has a big clot in it, very common with PICC lines that fail. Suddenly the PICC line stops working. You got to go put a central line in, and it's not going in. Well, on ultrasound, you'd be able to see that this is because it's got a clot in there, non-compressible. IJ. Center that vessel on the screen, and then all you got to do is aim the needle for the center of your probe. As long as the vessel is centered on the screen, right down the center of the screen, it's not over here, it's not over here, it's down the center. Therefore, you just aim the needle for the center of your probe. It's that simple. And if we're doing a peripheral line, we'd stop right there, and that's all you need to know. But we do central lines that are deeper in the body. So keep in mind that the deeper the vessel is, the further back away from the center of the transducer that you may need to stick the needle, so long as the needle comes in at a 45-degree angle. And this is the right triangle theorem or Pythagorean theorem. Okay, so I'll slow down and explain that one more time because I know that probably sounded pretty confusing and went pretty fast. So this is the transducer here. It's on like the skin, okay? And then from the transducer down into the lumen of the vessel, this distance, skin line to lumen, is x. And the distance from the center of the probe over here is x prime. These distances should be equal. So if you're doing a femoral line, it's 4 centimeters deep, well, you're going to choke back 4 centimeters away from the center of the transducer, so long as your needle comes in at 45-degree angle. And by the time the needle tip enters the sound, it's right in the lumen of the vessel. That's the idea. Now, as your mind starts to wonder, what if I put the probe in the long axis? Well, now the vessel is stretching out across the screen, and it'd be nice to be able to see not just the needle tip, but also the needle tip and shaft of the needle going in, and that's an elegant way to do it. And certainly interventional radiologists do stuff in the long axis all day long, sometimes called the in-plane technique. But as you can see here in this situation, we missed the vessel altogether. We hubbed the needle. Here's the needle shaft and tip here. It missed the vessel altogether. That's because the wedge of sound that comes out, the thickness of sound, if you will, is only about 1 millimeter thick. And it's just kind of technically challenging to get this little needle that's not more than 1 millimeter in thickness be underneath a millimeter wedge of sound. Is tough to do. And you could easily let that probe slide around and not be over the vein anymore, but be over the artery. So the downside to the short axis, though, is that we don't know which part of the needle we're seeing on the screen. You know, kind of gives you a false sense of security, seeing an artifact on the screen where the needle tip may be all the way down here. What you're looking at is part of the shaft. So just keep that in mind. So he's right over the jug. The carotid's down here. What you're going to see is a lot of tenting. The needle's coming in. Here's the carotid artery. Here's the IJ here. The needle's coming in. There's quite a bit of tenting. And with all that tenting, you're wondering, like, what's happening here? Did they unsharpen the needle and now it's like not going in? Go ahead and aim a little more lateral. It's common to see this tenting on ultrasound. Here we are on the short axis looking at this IJ here. Are you in? Not yet. Still not in there. And the reason for all this tenting is because the central lines that we're doing this on are patients who have very low intravascular volume, and that results in this easily tentability here of the vessel. That's why you got to put the patients in Valsalva, have the patient do a Valsalva technique. I tell the person to bear down like they're trying to have a bowel movement, but don't actually have a bowel movement. That last clause is important. You can put the patient Trendelenburg, deep Trendelenburg, have the patient so deep that the nurse has to hold their feet, and sometimes, oddly enough, humming seems to do pretty well to get these IJs to stay open. So when you're down in the groin, of course, it's the opposite of all these techniques. You have the patient reverse Trendelenburg, you know, so the blood goes down towards the groin more, and that seems to help. And then if all fails, you just sort of give it a big jab, and you can overcome the wall tension. Sometimes you end up back walling it a little bit, but you know, you want to pull back and just confirm that you're in the vein, not the artery. Femoral vein, there's a lot of pulsations during CPR. This is the femoral artery over here, the femoral vein. This is the patient's right leg. You can see the right femoral artery here, the right common femoral vein here. And, you know, there's all these pulsations going on during CPR. So just keep that in mind. The needle's way over here. You want to center that vein on the screen and aim for the center of the transducer. And then the other thing about femoral veins are kind of funny. This is the superficial artery here, and this is the deep femoral vein down here. The vein actually dies behind the artery as you go distally down the leg. You want to keep that medial lateral configuration where the structure that's venous rhymes with the organ that's right medial to it, the penis, venous penis, okay? And the artery is out here. So to keep those structures medial lateral and not anterior posterior, you want to be very proximal. If you go too distally, this vein will jump behind the artery. Subclavian technique is also an option. You want to, you know, basically start really lateral out towards the shoulder. The glenoid is like right here. You could put the probe out that far, and at that location, very laterally with the probe, you're not going to see a subclavian, but you'll see the axillary artery and the axillary vein actually quite well. Now, as you move the probe more medially, a couple centimeters medially, well, those axillary artery now turns into subclavian artery. What was once the axillary vein is now subclavian vein. This is the, you know, the clavicle over here, and, you know, blocking the sound. And so the artery is kind of hard to see, but the vein is still able to be seen. And this is what it looks like. So here's a subclavian artery, subclavian vein. The vein is here compressible. What do you think that white line is right there? Yeah, exactly. That's the lung. Okay, that's the pleural line there. That's why this technique is a little scarier, but certainly doable. You just aim, center that vessel in the center of your screen, aim for the center of your probe, choke back as far as deep as that vessel is. Now, what about peripheral lines? The research here is actually really good as well. And you want to use a longer angiocath in this technique. You want to use only a 2-inch long. You want to make sure you use at least a 2-inch long angiocath, because now that there's a probe in the way, you're going to need a little more distance for the angiocath to traverse underneath the skin, before it gets into the veins. You need a longer catheter that's going to stay in place should the patient move their arm. Structures that compress are the basilic vein, the brachial vein. The artery stays open. Here they are without compression, basilic vein, brachial vein. The names don't matter so much. It's mostly just wherever you're bouncing around the arm and you see structures easily compressed. Those are venous structures. Those are the ones you want to aim your needle for. This is what it looks like here. We're just compressing that vein, and we center it on the screen, and then a needle tip will come in. Boom, there we are in the vein. So that's a peripheral line, looks like a basilic vein to me. Center the vessel, aim for the center of the probe. And then once you're in, you put the probe down and advance your angiocath like you would any other IV start. So that's essentially it. You want to make sure you don't get too mesmerized by the ultrasound screen. Always have an idea where your needle tip might be. If you come in other than a 45-degree angle, you may not be in the right place at the right time here in the sound beam. So keep that in mind. We're used to doing IVs at this kind of 20-degree angle here, and so it's a little higher than that 20. 45 is up here. This is probably about 60 or so. This is too high. You're right around here, right about 45 degrees is the idea. And that's it.